Okay, let me start. So my name is Rick van Nuland. I'm a program manager at Ligature for the Bigpicture project. Welcome, everyone. So today we have a webinar on non-clinical pathology, or actually on toxicology pathology, by Julie and Brian. And actually, I think this more or less started from the concept that we are working in a very multidisciplinary project, right? We have veterinary pathologists, we have human pathologists, we have data scientists, we have infrastructure builders, we have people who are experts in legal. And actually, this whole collaboration, it starts with being curious about other people, what drives them, what are they doing. So then, and it was actually Julie who brought this up multiple times. So that's why she also raised her hand to actually discuss with us what is veterinary pathology and clinic and toxicology pathology more specifically, and with the intention to give you a little bit more insight in what is their daily routine of basically half of our project members almost, and give you the opportunity to also to learn about that and ask questions to better understand where they are coming from, what they're experiencing and facing in their everyday work. So like I said, this webinar will be provided by Julie Beauclair and Brian Knight. So Julie is representative from Novartis in Work Package 1. Novartis is the project lead. She joined a little later in the project, but she's very much up to speed now. Brian, who is working at Boehringer, Ingelheim. He's also a veterinary pathologist, and he is co-leading Work Package 3, so basically the data collection, but also involved in the Honest Broker task force. We said that we would like to make it more of a discussion, so feel free if you have questions, raise your hand or post something in the chat. And if you have a question, please unmute, turn your camera on so we can see who you are, so to make it a little bit more interactive. So with that, I think Julie, the floor is yours.
Thank you, Rick. So good morning, good afternoon, everyone. So we will discuss about what we are doing mainly in non-clinical notes. So for those of you who are curious, so I've suggested those meetings, as Rick said, because I'm a dummy in everything except ToxPath. So that's why I want to learn about all the other disciplines. So I thought that maybe some were curious also in what I do. So I decided to make this presentation. So first, we will discuss a little bit of the drug process, where we fit within the drug process. I will describe also what our regular standard toxicology studies look like. So what type of slides we will end up with in the repository for Bigpicture, and then why we were embarking us as a non-clinical pathologist in the digital pathology adventure. What is the difference between clinical versus non-clinical application for computational pathology, so AI modeling and machine learning. And also, I've prepared a few slides for non-pathologists and data scientists, where we are going through microscopic findings and pathology through the eyes of a pathologist, but explained for people that are not hardcore pathologists. So you can interrupt me at any time if you have questions, and I'll try to answer. So this is the drug development process. There is a box for preclinical, but honestly, it looks more like at the bottom where we are involved from beginning to end. We are involved at the time where we are doing either efficacy animal models for a certain disease, or even sometimes post-marketing, if there is a toxicity that is seen in the patients. Sometimes we will do a back translation investigation of the finding to try to find the cause, try to find biomarkers, or try to find a kind of mitigation strategy for the finding. So we are really the full breadth of the drug development process. We are involved all along it. The vast majority of what will end up in the repository of IMI Bigpicture will be the in vivo toxicology. But our preclinical safety groups are doing way more than that. So we do in silico work. So for example, we will check if based on the structure of the drug, we should expect toxicity. So already we have AI models that are doing these types of checks. So it will compare with our all database of drugs, the one that had toxicity and the one that didn't have toxicity, and will give a kind of a probability that we will have, for example, hepatotoxicity based on the structure of the drug. We are doing some safety pharmacology, so checking if we will have any cardiovascular effect. Will there be QTc prolongation, reduction in the blood pressure, increase in heart rate? So all these things will be monitored in a specific study or within our standard toxicology studies. We will check if the drug can do modification to the genes. Is it clastogenic? Do we have any changes to the genes associated with the administration of the drug? We'll do some immunology testing. Some of this will be in vitro, others will be in vivo studies. We can do also some developmental and reproductive tox, so checking if there are any changes to the hormones. Can we sustain a pregnancy while we are on the drug? Or do we need to avoid being pregnant while on the drug? And we will also have some carcinogenicity assessments. So some of these are lifelong study. The carcinogenic toxicity study in rats will be lifelong, well, lifelong for a rat. So it's about a 2-year study where we will monitor if they will develop tumors or not while they are under treatment. And when we have toxicity findings, we need to assess if we don't have, for example, what we call a therapeutic index, and that's between the dose at which, or not the dose, but the exposure at which we see toxicity and the exposure that will be given to the humans. If this number of fold is not very wide, we need to explain what is the cause, the mechanism behind it, and we need to do some investigative study to explain it, to find biomarkers, to take the decisions if we go forward in humans or not, or if you are continuing in human or not. So Brian will give you a very good example of these types of investigative studies. So the animal studies are required by the health authorities, and the goal is really to assess the potential toxicity of new drugs. And the most important study is what we call the IND enabling study, and it's to determine the starting safe dose that will be given to the human in the first clinical study. So we are working on a lot of initiatives, what we call 3R initiatives, where we would like to reduce our number of animal studies that we are running. And Bigpicture is part of one of these initiatives. We would like to use the slides that are in the database maybe to reduce the number of control animals that we put on a study. So there are also a lot of in vitro approaches that are being developed to reduce animal studies also, such as what we call organ on a chip or human on a chip. So before we had in vitro tests that was, for example, just one cell type within the Petri dish, but now they are making these very complex in vitro settings where there are several cell types, some, for example, white blood cell would be circulating, and it's kind of reproducing better what we have in animals. So I foresee that within, I don't know how many years, 50, 70 years, there won't be any animal study anymore. And Bigpicture will be part of this reduction. So in vivo tox studies, it's really a screening exercise. And what we are doing is for one drug, we will perform in two lab animal species, one that will be a rodent. Most of the time we use rat, and one that is non-rodent. We will perform this, we will give the drug, and we will give this at incremental dose. So we will have what we call a low dose, which is either the dose that will be given to the human or a few fold more than the 1, 2, 3, 4, 5 fold what the dose that will be given to the human. Then we will have a mid dose that is 10 times this or more, and then we will have the high dose, which is sometimes 100 times the dose that will be given to the human. Because we really need to see toxicity to be able to inform what are the risks once it's going to be given to human, and what we need to monitor when it's going to be given to human. So for each study, we will have both sexes. So we will have males and females. So this is important because there are some toxicity that, for example, the ones that are hormone related, that can be seen in one sex and not in the other. There will be, we have repetition, so we have 10 to 20 rodents per study, but 3 to 5 non-rodent animals per sex per group within each group. So as I said, we have one control group and 3 dose. So each time 4 groups control, and then low dose, mid dose, high dose. We harvest at necropsy about 59 organs, up to 59 organs, and we will examine those under the microscope. And this is really to find what are the target of toxicity for a given drug. And the dose are there to know if this is dose dependent. Are we expecting to see this at low dose? Are we expecting this to see only when a very high dose will be given? So the dose dependency is an important factor that we need to look into. During the in-life phase, so while the animals are given the drug for a certain time, we will also monitor a lot of things. What are the clinical signs? Do they lose body weight? We will monitor at the end the organ weights also, compare them to the control. And we will also take several measurements in the blood, in the urine. So we will perform hematology, clinical chemistry, urinalysis. We will harvest blood and organs also to perform genomics at the end of the study. So this is to determine if there are any biomarkers that we could use that could be prodromal to detect the toxicity faster than and to be able to stop the dosing once we will be in the human, a kind of measurement to stop the dosing. We will measure, of course, the exposure. So what is the concentration of the drug in the blood or in other organ? So, and this will allow us to calculate this therapeutic index that I was talking about earlier. The dose in the human, the dose that is toxic in the rat, what's the distance between those two exposure, and this gives us comfort that it's safe for human, or, oh, we need to monitor this. And if it's for a disease, we need to make a kind of risk-benefit assessment. So if it's for oncology, we are allowing to have therapeutic index that are narrow because the risk is very high of continuing to have a tumor. But if it's for blood pressure monitoring, we don't allow these low TI. So, and during the drug development, we will give the drug for longer duration. So this allows us also to give the drug for longer duration in the human. And the first few studies we will do, usually they will be non-GLP. So this is the regulation under we are working, which is good laboratory practice. In clinics, it's good clinical practice. Us, it's good laboratory practice. So the first study are of shorter duration, and they just allow us to tease what are the doses that we should give in the first GLP study. And the IND enabling study will be the one that will be done before any drug is given to any human. This is one of the most important study that we are running for non-clinical, because after that we start to have human data. We start to see, once it's given to a lot of humans, to see if they react like rat or not, if they have things that are similar, what is the exposure, are they exposed more than our animals, less. So the more human data you have, the least animal data are important. So for us, the 4-week GLP study or IND enabling study is one of the most important. Jan Willem?
Julie? Yeah.
Jan Willem?
So so I had some difficulties unmuting. So I was wondering, so why are you doing the first studies without GLP conditions? So what does that add for you?
I mean, the GLP is always a little bit of a complication. It's just, we are often doing it GLP like. It's just that there is no kind of audit that will be performed by the QA. And this allows us to have more flexibility to react more quickly. But in all honesty, they are run the same way. It's just that often we will have only target organs that give us a go or a no-go. So for example, we will not sample salivary gland or things that we sample. The 59 organs is, for us, for example, in Novartis, we probably look at 25 organs during those studies. It's really the go, no-go organs, the liver, the brain, the kidneys, the ones that are really the heart, the ones that are really giving go no go decision. And during those shorter non-GLP study, what we are doing also is often we have several drugs for the same target, right? We will give them in parallel and decide which one we really want to go forward with. So, and then in the 4-week, it's going to be the one, okay, we decided to take this one because the PK/PD, the exposure is better, and also it's more efficacious, and it's inhibiting more our target or less. So that's why those are done often non-GLP and in a less cumbersome way. So this duration really allows us to check if we have any progression with time. So this is a good assessment also, because if something shows up, then we know if with time, if we increase the duration of the treatment, does it do the same toxicity, or does it progress? Do we have necrosis and then fibrosis, or do we have just single cell necrosis and no other secondary effects that are due to progression? And within these studies also, what we will do is we will have a recovery phase. So this is a phase where we are giving, during the main phase, we are giving the drug for the certain amount of time that you see there. And at the end, we stop dosing and we let them without dosing for a period to see if I have necrosis in the liver. If I look 4 weeks later, do we have still necrosis, or has it stopped and has it recovered? Anna? Anna, can you put yourself on mute?
And Ariel had a comment in the chat that GLP is the quality management system in non-clinical sciences, similar to the ISO norms in the sense.
Yeah. So that's why us QMS is so near to our heart. It's because we are always under this type of management. So if there is no other question, I just want to go through what is what a typical IND enabling study look like. So this is the first study that is given before we are we will give the drug to humans. So Most of the time it's a 4-week study, but what we need is it needs to be at least or longer than the duration of the treatment for the first phase in the patient or in healthy volunteers. But the vast majority of the time, we are just giving it for 4 weeks and looking what it's going on. And then we will have a recovery period of 4 weeks. So we give the drug for 4 weeks, we stop giving the drug, we wait for a week, and we look if we still have toxicity or not. There will be 10 rats per sex per group in the main phase, and then the recovery phase is going to be 6 rats per sex per group. We have the vehicle control group, treated group, the low dose, the mid dose, and the high dose. And at the end, we will do the necropsy, where we will sample everything during the in-life. So we will have all the clinical pathology, urinalysis, body weight, clinical signs. So all these things will be recorded during the in-life. And at the end, we will perform a necropsy, and we will harvest approximately 50 organs per animal, but these will be put on 20 slides. So for us, that's important when we will do the models, because it means that for some slides, we will have several organs on them. So that's different from the clinic, where often you will have, for example, the same tumor but different staining. Us, we will have an H&E staining, but with several organs on them. So we will have some segmentation work that will need to happen before we are able to apply AI to an organ. Usually we don't examine and process all slides. What we will do is we will look at the control and the high dose, all organs, but we will determine in the high dose what are the target organs of toxicity, and from the low dose and the mid dose, we will look at this target organ of toxicity. And in a study, we have, well, in average 5 to 6 target organ per study, sometimes 0, sometimes it's all organ when we have phospholipidosis, for example, which is when the drug gets trapped inside the lysosome. Sometimes all the cell type can have the vacuolation that is characteristic of phospholipidosis. I'll show you an example later. So the primary evaluation is usually done in a CRO or by a first pathologist, which is a study pathologist, and then there will be a review that will be done by a second pathologist, which we call the peer review pathologist. And often the CRO pathologist is in a company, and the peer review pathologist is what we call the sponsor. So it's coming from the pharma, and this person will review a subset of slides to confirm what the primary pathologist or the study pathologist has seen. And they will discuss together, discuss of the terminology, and so on and so forth. And these studies are about 1,200 slides per study. So this is what we will have mainly in the database of IMI Bigpicture. And the reason why we decided to go forward with digital pathology and why us it was so important is you saw that we have a primary pathologist looking at the slides, and then another one that is kind of reviewing the slides. And because of that, we need to ship the slides, count them, blah, blah, blah. And it was very cumbersome. The workflow was very cumbersome. So for us, digital pathology was really improving our life by optimizing our workflow, where the slides can, either be accessed via internet or, sent on the cloud and downloaded. So this has really improved our life. But we want to go further than just digital pathology. So we want also to apply AI and machine learning and AI to our site. But the application is a bit different in non-clinical than it is in clinical. So in clinical, often it's more narrow because it's one organ and or one tumor in one organ. So the diagnostic is done by the pathologist. We have H&E, but we also have a lot of molecular staining, and the staining you decide on is specific to the tumor or the organ. And the AIs will be used mainly for prognostic feature or find metastasis a lymph node, for example, and those models are not generalizable. But as you have seen in our workflow is it's more a screening exercise. So our application will need to be more broad. So where are the lesions? That's what we need to find. There is no exhaustive list of lesions either. You talk to any one of us in the non-clinical node. I've been doing this for 20 years, and every year I'm surprised by something I've never seen before. So there are no prior diagnoses of us. We want to apply it before the pathologist has looked at it. And it's most of the time we only have H&E. We have several species. There are 59 organs. So this is not it needs to be more holistic, the approach. So it's really to help the pathologist in the diagnosis. And we cannot use a lesion specific or an organ specific model. Otherwise, we will have like tons and tons and tons and tons of models. So that makes our life a little bit more difficult.
Julie, there was a question in the chat. Who is doing the peer review? Is this a pathologist from the same company or from an external, or is it an external consultant?
The vast majority of the time, it's the pathologist from the pharma. So, for example, us in Novartis, we outsource all our studies, and in the CROs, the pathologist from the CRO will read the slides first, and us, because we have the knowledge of the project, we know what was seen in the previous studies, and we know the target, we know what to expect. It's going to be done by the pathologist from the pharma. And sometimes we hire a consultant also to do it. So I'll go quickly because otherwise we won't have time for Brian. So the microscopic evaluation, this is a little bit like, in the Sunday Journal when you are playing this game where you have two images and the guy is missing his bow tie, and then it has like flowers missing in the flower pot. You need to find the errors in the two image. That's more or less our day-to-day work, except a little bit more complex. So this is, for example, an example on the left-hand side, you have a control. On the right-hand side, you have a treated animal. And this is what I said, it's phospholipidosis. So the drug is stuck in the lysosome. And you can see that, for example, in here, you have the Kupffer cells that are full of vacuoles. You have the hepatocytes here in the centrilobular region, which are the ones that have also vacuoles compared to those that are here in the same region. You have the bile ducts that are paler and bigger, again, full of phospholipids. Here they are almost inconspicuous. So the finding is really just it's almost a game. It's what we are doing on a day-to-day basis.
Julie, there was another question in the chat. So the 1,200 slides per study that you had spoken of, and these are covering all 59 organs, or is this already a subset of organs when we do that 1,200 slides?
So the 1,200 slides, we will have, as I showed here, the control and high dose, we will have all the 59 organs, but the target organs, we will only have the target organs in the mid dose and the low dose, usually. So that's how, if you calculate this thing, if you have 5 to 6 target organ and the number of animal, it's not like 59 multiplied by the number of animals. You will see that it's a subset of slides usually that we have. So I prepared this, but I'm not sure if we have time to go through it. And we will share those slides, right, Rick? Yeah. So, I mean, it's more, and what we can do also is have another session. It was just a kind of microscopic evaluation explained to non-pathologists by a pathologist. Yeah, I don't know. Should we go through it or should we go to...
Yeah, Julie, go ahead, and I can probably go through my slides fairly quickly.
Okay. Okay, so I'll try to be quick nonetheless. So just to show you a little bit how our brain is working. So as organs, it's a 3D. So if you have a liver that's like this, and us, what we will look at is only a 2D version of it, and it's a very very small samples. It's 4 to 5 micron thick, so very minuscule, and it's stained with an H&E, and the H&E, the nuclei, so the nuclei of the cells will be in purple, and then the cytoplasm, which is full of protein, and also the connective tissue, they will be in shades of gray. So we are in 50 shades of gray and of pink and blue. And these 3D organs, they are made of epithelial cells, connective tissue, vessels, nerve, and they will be the configuration they will take will be kind of organ specific. And of those 59 organs, you are thinking about their composition, they are about 500 tissue components. So endothelial cells, tubules in the kidney, the glomeruli. So when you think about it, the complexity is really increasing. So and some of these tissue components are seen only when we have pathology findings. So, and others are seen when also in control. They are there in control, but they are kind of not dilated. They are small, and we cannot see them. So sometimes in control, you cannot pinpoint where the canaliculi is between two hepatocytes. But the day we have cholestasis and bile accumulates in there, then it becomes dilated and it is visible. So it complicates a little bit the learning when you are doing a kind of model, because sometimes in the control you cannot see it. Then each organ is done in region and substructure, and these region and substructure, they can be specific to certain organ. For example, the glomeruli, we only have them in the kidney, or they can be also shared between organs, like the vessels. We have arteries and veins in all the organs all across the bodies. So, and the way we will be describing our finding, the substructure or the region will often be used as a locator. So I have necrosis, but I have necrosis where? It's going to be in the hepatocytes, is it in the bile duct? So we will often use those locations to help the description. So, and as I've shown you with the game between the treated and the untreated, findings is just normal histology gone wrong. So if a model is learning normal histology, it will see that the treated animal is an outlier. When you are looking at tissue primitive, it's a finite set. We know exactly where it ends, and that's why an histology book is 150 pages. But when you look at pathological findings, it's tomes and tomes and tomes of thousands of pages. So this is not finite. And findings can be very different. It can be an increase in size, cells that are disorganized. It can be degeneration, regeneration. So, and often it's more complex than this because it's a combination of the above. So it can be seen sometimes in a very, you need to go at very high magnification to see them, like a mitosis, for example, or an inclusion inside a nuclei. Or it can be very big, and then you have it on several. If you are tiling the organ, you can have it on several tiles. It can be focal, it can be multifocal, it can be diffuse in all the cells. So this also needs approaches that sometimes need to be tweaked to be able to detect them with machine learning. So controls are not always controls. So like us, animals are sick, they can have findings. So we have background change that are associated with certain strain. We have background change which are associated with certain species. So it's not because it's a control that there is no finding in there. So sometimes we will call something in one organ, we will use the same word in another one, but they will look totally different. So we need to be careful about those things. So I think when we are nearer to do the lesion detection case, maybe also we can have more of these discussion between the non-clinical or the toxicologic pathologist versus with the data scientist to help. So that's all for me.
Very good. So hopefully you can see my slides coming up now. And let me just move this tile over. Great. So I wanted to chat with you a little bit in regards to, you do see my slides on the screen? I don't seem to see it on my version. Oh, it looks like there's okay, very good. So I'm going to speak to one of the investigative assays that we did in relationship to empagliflozin. So I'm going to just run through this really quick, give you some background. So empagliflozin is an SGLT2 inhibitor. So that's a sodium glucose transport, which is a ATP dependent transport, and it occurs in the in the glomerulus. A lot of glucose comes across the basement membrane of the glomerulus and into the filtrate. And so that glucose needs to be resorbed. It's typically resorbed in the proximal convoluted tubule. And if we look at that in cross section, one of these cells, then, we look at one of those cells, and it inhabits the brush border of near the lumen, the top of the cell, where the basement membrane, it would be down here, and then the glucose is transported from the urine across the cell back into the blood. So if we inhibit this process by using empagliflozin, we don't get urine glucose reuptake, and therefore we decrease blood glucose. So great for type 2 diabetes. And so then we decrease this in the blood, then we can modulate the amount of insulin someone needs based on doing this type of a therapy. So it can be helpful in that treatment. Where it became an issue is that we had to do 2-year carcinogenicity models in both the mouse and the rat. And in the early studies, we had to do a 13-week range finding study for this carcinogenicity study. And we noticed that there was a little bit of single cell necrosis in the kidney. But at the end of the carcinogenicity study, we had renal tubular adenomas and carcinomas appearing, and we had to understand why this was occurring. Interestingly enough, it only occurred in male mice. There were no renal tumors observed in the female mice, nor in the rat study. There were no EMPA-related proliferative changes in the kidney at all, so male or female. And so when we did the genotoxic assays with this compound, it was determined that it is a non-genotoxic compound. So therefore, it wasn't a direct relationship, but there had to be something that was going on. And the question was it related to superpharmacology, or is it an off-target type of process? So we had to devise a study. Just to demonstrate, this is what the lesions look like. We have an adenoma over here and a carcinoma on this side. And so we had to understand what the process was to get to this endpoint, and what its relationship then is for the path forward. So we needed to establish in this path forward planning, we had to establish what the chain of pathological events that occurred in the animal to result in this tumor, and then identify, once we understand this pathogenesis, we have to understand what is the human relevance of each step, so that we can understand the risk to people. So we propose the sequence of events that occur for this tumor, and we know that the CD1 mouse has a cystogenic background, meaning that it causes renal cysts to occur as they age, just inherent in their genetic makeup. And they also have a diminished oxidative stress handling. And we know that the pharmacology of the compound does increase some renal stress in that it increases the urine output. As you excrete more glucose in the urine, water follows water follows the glucose, so you have an increased urine output. So we are knowing that we are increasing the shear forces in the tubules because more urine is being processed. And so then we also wondered, this is kind of a pivotal event. We felt that it was a non-pharmacologic related reason for the transition into a tumor, and we needed to understand that much more better. So we designed an investigative pathogenicity study. And in this study, we had a 13-week study because originally, as I said before, the range finding study was a 13-week study, and we did see single cell necrosis. So we wanted to understand how this came about as a time course in the mouse. So we conducted this study with interim necropsies. We did a 1 week, 2, 4, 8, and then the final necropsy on week 13, collecting full set of samples. So we had low, mid, and high dose in this study as well. So this is similar to doing 5 typical studies in one study because we have all these time courses, but we have much fewer tissues. We're concentrating mostly on the kidney. But we also collected a lot of other samples as well because we wanted to explore not just the histopathology, but we wanted to do RNA-seq along the way and look for biomarkers. So we collected a lot of urine samples, a lot of blood samples, a lot of tissue samples, both frozen and with RNA later so that we could process these correctly. So just to demonstrate what the lesions we saw during this study. So the first thing that we saw popping up in this time course study was at 4 weeks, we started to see single cell necrosis. And also during that 4-week interval, we also started seeing mitotic figures. At the 8-week interval, we started seeing larger than normal. And this is a subtle lesion that many may not pick up on, but the size of the nuclei of some of these tubules is a little bit larger than what the others are. It's a very subtle lesion that you don't easily pick up on when you're at low magnification, but at higher magnification, trained pathologists, we do pick up on these things. And then another aspect that came about at the 8 weeks was that we would sometimes see these binucleate cells within the proximal convoluted tubules or multinucleate cells, and this one has quite a few. And these might be the precursor of moving towards a neoplastic entity. But one very interesting thing that we came across because of this, we tried to understand what could be the causes of an oxidative stress. So we looked at the metabolite structure, and there was one metabolite that was extraordinarily high in only the male mouse. But this metabolite wasn't in itself was not a potent toxicant. However, it did tell us that to get to that endpoint, there was a conjecture of how it could get to that endpoint of a metabolite in the process, and we had to do some trapping of a molecule that was very quickly metabolized to the end metabolite. And it turns out that this 4-hydroxycrotonaldehyde is a very potent free radical generator. So there's 2 pathways of metabolizing this drug, and one is through glucuronidation, the other is through oxidation. Humans only glucuronidate. Rodents either glucuronidate or go through the oxidative pathway. In the kidney of the male mouse, driven by testosterone, the oxidative pathway is pushed up to 99% of the drug is pushed down to that pathway. And so this crotonaldehyde then becomes 1,000 times higher than what is in the female mouse. And it is believed that that free radical generation of that extremely high metabolite was what was then causing a non-genotoxic tumorigenic mode of action, so that you were constantly killing off individual proximal convoluted tubule epithelial cells, and then you had to regenerate those, so increase mitotic figures. Every time you run through a mitotic event, the chances of having a uncontrolled or unregulated proliferation can increase. It's just the odds. The more times you roll the dice, the higher percentage, or the higher times you'll see snake eyes type of thing. And so by increasing the number of rolls, by killing off cells and having to regenerate those, you now have the potential of creating these tumors. And so these in vitro studies that we performed demonstrated that this crotonaldehyde is very toxic to the proximal convoluted tubular epithelial cells. But again, it is non-genotoxic. And so just as a conclusion, we demonstrated that we showed the expected pharmacologic effects of osmotic diuresis. Putting more sugar in the urine pulls more water into the urine, increases the volume of urine. And we demonstrated that we saw the findings only at the high dose males, which was consistent with the long-term studies. We also did a lot of RNA-seq assays, and we found that in the animals with lesions, that there were a lot of transcription changes for the increase of the cell cycle regulation, cell proliferation, cell-to-cell signaling, and cell adhesion, as well as the cytoskeleton. These were all upregulated in the male. And all of these features then came to support that the role of the early empagliflozin-related degenerative and regenerative changes, which were only observed at the high dose in the CD1 mice, was the key contributing factor for this non-genotoxic mode of renal tubular pathogenesis. So we went through this study kind of quick, but one thing that we did in this study was we determined by Ki67 the number of mitotic figure, or Ki67 positive cells, which means that they've entered into the cell cycle regulation. And at the time, we were only using definiens, which was an if-then statement, complex if-then statement type of image analysis, but it was handwritten for specifically for this study. So we did not have AI available to us at this time. So now, looking at the AI available, things that we would love to have done then is to be able to just go through and find all the mitotic figures, all the foci of single cell necrosis, all the karyomegaly, all the multinucleate cells. Find all those, quantify all those. We could get statistics. Maybe this might have snuck down into the mid dose. Maybe we weren't astute enough to find those subtle changes. It may not have changed the outcome of this study, but it would have been an interesting understanding of the pathogenesis to have that information. Now, the next step of the phase is that we have this interesting drug with the interesting lesion. Now, what if we get another drug 10 years from now and I'm retired and everybody else that worked with me on this project is retired? They may not remember these types of things. If we had an algorithm that would go through our database and pull out all those studies that had single cell necrosis or increased mitotic figures, or any one of these features, or any combination of these features, pull them out and mine that data. Well, we had 15 types of this drug and 15 hits on this other drug, and what are the commonalities between them? That would then help us understand pathogenesis better. You know, we did a lot of work on the understanding of this pathogenesis. Do we really need to reinvent the wheel the next time, you know, years from now, when we don't have that institutional memory to be able to pull this information forward? And so with that, I know I ran through it kind of quick, but I wanted to make sure we got through it with all the slides, and then open it up for questions.
Thank you very much, Brian, and Julie as well, of course. I see there's a hand. Give me.
Joel?
Yes. So, excuse me, I'm not coming from a pathologist background, so you have to excuse my very novice question. But at what point?
That's why we are here, Joel.
Yeah, exactly, exactly.
So, at what point do you decide to go from an animal study to human trials? How do you know when to go there?
So generally what happens is if you have a clear therapeutic margin above or that is well below, multiple fold below what a toxic uh, uh, incidence is, then you're safe because you then go into the first human study. It's typically a healthy volunteer with most indications. Some indications go directly into patients, but if you go in low and slow is typically the mantra that people use. So you give it to a healthy volunteer at a very low dose, and you know you have the safety margin from the known toxic event that happens. So if you give it low and monitor for those biomarkers that we identify in these tox studies, whether it's blood, urine, or some other type of an endpoint, you can go up to what the expected therapeutic level is and even above the therapeutic level to understand what is acceptable to the human. So anything found in the human is going to trump what we found in the non-clinical, but the non-clinical helps us set those safety margins in which we can then begin starting in the human. So we can't give a drug to a human for longer than what we gave it to an animal. So if we want to do 2 weeks as our first in human clinical trial, we have to do at least 4 weeks in the animal studies. And if we, or excuse me, if I think I said 2 weeks. So if we do 2 weeks in human, we have to do at least 2 weeks in the animal species. And if it's 4, we have to do 4, so on and so forth. But we typically do a little bit longer. So, and if it's a drug that is going to be dosed for the lifetime of an individual, that's when we need to do the carcinogenicity studies, or maybe not the lifetime, but multiple years of treatment. We want to do the carcinogenicity assays to understand any risk that might be derived from long-term exposure. Did that help with your question, or was there something?
Thank you very much,
Okay.
Brian. Thank you.
Sure.
Any other questions? Otherwise, I may have one. So Julie, you talked about kind of holistic or models that can be kind of more generalizable. Let's put it that way. So do you see more value in models that can screen multiple organs for basically outliers, or models that you can check one organ but in multiple species, for example, that are transferable?
Yeah, I mean, the approach, you can probably arrive to the same conclusion with both approaches. It's just the model that is more holistic, then you don't have to maintain 100 different models, for example. Because as you have seen with the GLP environment, we need to do this in a validated way. I don't have an answer to your questions at the moment, because we are exploring if we can have an holistic approach to this question, but we will need to also compare it to a more specific approach to see if it's good enough, the holistic is good enough, or if we will need to have a more targeted approach than the holistic one. So what we are using is you've seen the paper by Pierre Moulin, where we have trained a model to recognize to recognize organs. So there is enough features that are made by this model that we can compare control and treated like this and say, yes, there is something, or no, there is not something. And I mean, we have some good results at the moment. What we will do is, if we are allowed, we will probably make a presentation up to a point to the IMI Big Picture with our result, hopefully in a few months probably.
It will be really great, I think. Let's see if there's no more questions. I think, of course, people can always direct questions to Julie or Brian also after the meeting. I think you're available, right? So shoot them an email if you have additional questions. I think it was very insightful, at least for me, from not being a pathologist at all. Before we leave, I just want to share my screen and say a few more things. Yeah, so I think so. This was another great webinar. I think. Keep in mind, we try to have these webinars every month. So next month, and in fact it's in 3 weeks' time, we have a webinar by Gabriele and Xavier, which is on also more on FPI perspective, but it's more about the landscape of guidelines, standards, and regulatory requirements relevant for digital pathology. That's on the 10th of June, so the registration link is has been sent around. So please register. So during the summer, we don't have any webinars, so not in July nor in August. But after that, we have a couple of very interesting topics. So one on explainable AI, and some others more on clinical pathology, like how are we going to select data sets, but also on ontologies, one on federated learning, and one on an initiative that's running in the UK on kind of boosting digital pathology in the clinic in the UK. If you have any suggestions for webinars, feel free to contact us. I think it's important that we keep sharing knowledge. We keep being curious and asking each other questions. So please help us to define, okay, what are the questions and what are your questions, so we can design a sharing session like this also in the future on your favorite topic. With that, Brian, Julie, thanks a lot for your contribution. It was very
pleasure.
nice.
Yes, certainly.
And, I hope to see you on the 10th of June.
Thanks, Rick. Bye, everyone.
Thank you. Take care.
Thanks. Bye-bye.